I just want to introduce myself. My name is Andréa Caballero, and I am the Program Director at Catalyst for Payment Reform. I'm also a part of the LAN operator team, and I'm really delighted to be here because today we're going to talk about the APM results from this year's measurement effort. So I'm joined by my fellow panelists here. You can see all the way down to Olivia. So Ellen Lukens, who you've heard from before, Deputy Director at CMMI. Laura Fox is the Director of Payment Innovation from Blue Shield of California. Abby Malloy is Staff Vice President at Elevance Health. And Olivia Alford, Director of Delivery System Reform with Main Care Services. So I have the honor of being here today and to actually present these results to you. But I could not do this on my own. There are a lot of people that I really would like to thank because this is a national effort. It takes a lot of people to put this together. So I want to thank my CPR colleagues, including Dane Slay, who's here. Also, Meghna Sharma, Cassidy Estep, Shannon Petchel, and of course, the folks from CMMI, Kate Davidson, Rusty Walker, and Eric Wallstrom. So this is a effort that we all put in together, and it's kind of a sprint at the end, and so I'm really excited to be here. I was encouraged to share a little bit about the LAN framework, and I sort of live and breathe this all the time, so I sort of think that people do as well. But in case you don't, this is the LAN framework by which we measure alternative payment models. So the first category is orange. That's fee for service with no link to quality. The second category, which is in red here, is still fee-for-service, but there is some link to quality. There are some quality incentives here. And you can think of this as infrastructure payments, care coordination, and pay for performance. Category 3 is in purple, where it gets a little more technical in terms of at least the way we measure. So it is also built on a fee-for-service chassis, but there are cost and quality targets. So it's important for me here to distinguish between subcategories 3A and 3B. 3A is our models. You can think of them as shared savings models, which are upside financial gain only. Category 3B includes downside financial risk, and this is where you can think of your normal shared risk models. And finally, we get to category 4, which can include capitation, partial capitation, comprehensive population-based payment, and also integrated finance and delivery systems. So this is the framework that we've been using since the LAN's inception to measure the adoption of alternative payment models. There's a process that we go through each year, and I'll kind of give you an overview of what that calendar looks like. But each year, we are looking at the prior year's data, the spending data. And so we're looking backwards. There is a little bit of a data lag. So we're going to be looking at 2022 calendar year data. And I mentioned individuals before who really help with this effort, but we also could not accomplish this without the partnership that we have with AHIP, Blue Cross Blue Shield Association, and CMS. AHIP and BCBSA are partners with us in that they field the same survey with the same questions and answers so we can aggregate their member plans results with the LANs. BCBSA does the same thing, so I want to thank Ashley and Danielle for their support here. As I said, CMS has been a partner as well, so we will look at traditional Medicare data. And the LAN actually collects data if it's directly from a state Medicaid agency, so we've got Main Care here. We can collect data directly from states, but also from health plans who are not participating through a national trade association. This is just a little bit of the timeline. When I said it does take a lot to go through all of this, we start really at the beginning, really right after the summit. We're already looking into next year. And we start with asking health plans if they would like to participate in the measurement effort. And if you are a health plan out there and you're not participating and you would like more information about that, please let me know. We would love for you to participate. But we start the recruitment process, we hold training sessions, we do one-on-one sessions if you have any questions, and then we initiate the data collection, which is typically at the end of May and we wrap up data collection at the end of July. So we have about a 2-month data collection window. And then our respective organizations look at the data, aggregate it, and then at the beginning of September, everyone submits it to the LAN, and then we aggregate it so we can present it here at the summit. If you would like more information about the methodology that we use and that our partnering organizations use, our methodology report is on the website. So I encourage you to look at that. And for anyone who wants to learn about numerators and denominators and definitions, all of that information is in the methodology report. I think Mark McClellan shared this earlier today when we sort of started the session about the LAN's APM goals. And so this is just a reminder that the LAN does have APM goals by line of business by 2030. So you can see there each line of business, Medicaid, commercial, Medicare Advantage, and traditional Medicare have goals by 2030, but that can really feel very far away. And so there are some interim goals that we have in 2024 and 2025 by which we can measure our benchmarks. So now let's get to the actual results here. And Mark also said earlier that the all lines of business, which is the large cylinder there, had some pretty significant gains in downside risk this year. So this represents data from 64 health plans, 4 state Medicaid agencies, and CMS, traditional Medicare. And you think about that, and it covers the spending for approximately 264 million lives and about 86.7 people covered under an insurance plan. So we're really covering a lot of spending and lives through this data collection effort. When I look at the data, when it comes into me sort of in its semi-raw form, I like to look at what's happening in all lines of business. So let's merge all of the data together and see if there's anything I can pick out of there. And this year it was pretty obvious what we could see. So in all lines of business, if you look at the green and purple, so that's categories 3 and 4, 3B and 4, that's the dark purple. 24.5% of healthcare spending is going through downside risk arrangements across all lines of business. And so this is a 5 percentage point increase from last year's report or 2021 data when it was 19.6%. Then I backtrack and I look into the individual lines of business to see like where can I find some nuggets of information. And in the commercial market, you can see that 16.5% of healthcare spending is going through downside risk arrangements. And this is an increase of almost 4 percentage points per year. So in the commercial market, just to put it in perspective, a 4 percentage point increase year over year is the largest in the commercial market that we've seen since we've been collecting data at the subcategory level. Medicare Advantage has always had the most in downside risk arrangements since we've been measuring. It's currently at 38.9%, which is an increase of almost 3.7 percentage points from last year. And then moving on to traditional Medicare, Medicare has 30.2% of dollars in categories 3B and 4. And this is a large headline for traditional Medicare and for all lines of business that traditional Medicare had the largest increase in downside risk of all lines of business. It had an increase of almost 6.2 percentage points from last year. And then we look at Medicaid. It's at 18.7%, which is an increase of just over 2 percentage points from last year's data. So it's a lot of numbers. I think increase is what you're hearing. But one of the biggest takeaways I would say is that when you look back at 2020 data, every line of business saw the most growth in 3B. So that's the dark purple sort of cylinder there. If you want to dig deeper by line of business, each of these are interactive on the website, and you can click on it and you can see what percent is 3A, 3B, and so forth. But every line of business saw its greatest increase in 3B in shared risk arrangements. So the movement to downside risk seems very real. You may not know that we don't just collect APM data. We also collect some qualitative, or it's not exactly qualitative, but some informational data points from health plans and states on their perspectives about other things, in this case, health equity. So we at the LAN, like many people here, are very interested in understanding how value-based payment arrangements are used to address disparities in care. So we field 2 informational questions, and we ask health plans and states which strategies they're using in their value-based payments to address health equity. So this year, 2 of the top 5 answers on the left-hand side, this is where we ask health plans, are you using value-based payment incentives to improve or address health equity? And 2 of the top 5 answers are both on the collection of data, which we know is crucial in order for us to address disparities. So one is the collection of standardized race, ethnicity, and language data, and the other in the top 5 is collecting sexual orientation, gender, and identity data. On the right-hand side, that's a subset question we ask. So we say, are you using incentives to address health equity? If the answer is yes, and they've selected what they're using, then we ask them, of those strategies, what are you doing related to social determinants of health? And the answers to this question was the most reported strategy is screening for socioeconomic barriers known to impact health outcomes. And then 2 of the top 5 are actually services that address socioeconomic barriers, such as referrals to CBOs, which we heard about in an earlier session, community-based organizations, and care coordination. So on the website, you can see how the responses from health plans and states changed from last year to this year in terms of increase or a decrease. Finally, we've heard in probably all sessions today about accountable care and the importance of accountable care in APM adoption, transforming care delivery, and the LAN wanted to learn how to measure lives in accountable care. The LAN adopted a definition in 2022, and CMMI, in its refresh, set a goal for itself that we've heard about earlier today, that 100% of Medicare beneficiaries will be in accountable care by 2030. So if the LAN is going to measure something, we need to have sort of numerators and denominators and some parameters. So there are 2 parameters here that we used when we were designing the metrics. The first is that in order for something to be considered an accountable care arrangement for the purposes of our survey, the care must be longitudinal in nature. It has to be longer than 6 months. So we're sort of taking out or excluding your episodes, which might be 3 months or shorter. The second element is that the payment model must incorporate accountability for total cost of care. So we developed new metrics. We fielded them for the first time this year, and we essentially asked of health plans and states, of the members that you have in categories 3 and 4, how many of them are attributed to a provider who's in an accountable care arrangement that meets one of these 2 criteria, not one of the 2, both of the criteria, excuse me. So for the first time, we're able to report this data. These are the percent of lives in accountable care arrangements. And in 2022, across all lines of business, this includes traditional Medicare, just over 36% of lives reported in the data are in accountable care arrangements. You might not be able to see that there, but the figure represents 5 million lives. And so 36.1% of people represents 93.1 million lives in accountable care arrangements. If you pull out traditional Medicare, you can see that 46.6% or 13.7 million Medicare beneficiaries are in accountable care. So this is new data for us. We've learned along the way here about how we can track this over time, and we hope to be able to report this by line of business at the 2024 summit. So with that, I am going to turn it over to my panel, and we're going to get into some questions, because that's a lot of data, but the real information and the real richness here is trying to understand what's going on in each of the market segments behind the data. So I'm going to start with Ellen, and with that last data point, actually. So the Medicare data shows that 46.6% of traditional Medicare beneficiaries are in accountable care. So why is it important for the land to track this data, and how will CMS move forward to achieving its goal by 2030?
Yeah, I mean, I'll say that actually we're really encouraged by these data, both the LAN APM measurement as well as the accountable care goals. So as you know, when we're thinking about accountable care, I think all of us would agree what we're trying to drive toward is really better care for patients. And so thinking about accountable care as a mechanism to really drive better clinical outcomes, higher quality care, and then hopefully also savings to Medicare. And I think in terms of CMS's perspective, we're really excited about these numbers because we feel like this really reflects additional participation in existing models. 2022 is really before we had the new models that were recently announced. So it really shows that that increased participation in the ACO models as well as in some of the advanced primary care are really bearing fruit in terms of beneficiaries in traditional Medicare really having access to an APM. So I think we're really excited about these data and think that the land measurement is critical to moving us all forward.
Thanks, Ellen. Laura, I'm going to turn to you. For the commercial market, I should have said each panelist up here is representing a different perspective. So Laura is representing the commercial market from Blue Shield of California. So we observed during the pandemic early on the fragility of the fee-for-service system and providers having to cut back on staff, closing offices, not being able to provide services. And so as we went into the 2022 data, I was looking for little pieces of information about, okay, there's lots of speculation about moving to capitated payment or per member per month or upfront payments to help bring that stability and known financing for providers. But we didn't see that in the data. Where that would have shown up, if you guys are going to look online, it would show up in category 4A or 4B, most likely 4B. And we actually didn't really see much of a bump there. So I'm curious, Laura, from your perspective, do you think, what are the barriers for providers, since that was really such a major issue and it hasn't shown itself in the data yet, maybe it will next year, but what do you think the barriers are to providers accepting that population-based payment and moving into that system?
Perfect. So I'm with Blue Shield of California, and so we represent a large number of our commercial lives. And so I would say the biggest barrier that we faced is actually providers wanting this. So we heard from the providers during the pandemic, we need steady income, help us. Like, we are closing our doors, what can we do? I will tell you, the health plan, we stood up. We came up with models, we operationalized them, we were ready to go, and we got to their doors and said, here, this is what you've been asking for. And they kind of paused and said, actually, this is too much, this is too different. We want fee for service. And even on their systems, and it was difficult for them to understand what this meant for them. And I shared this a little bit in my panel earlier for those that were there, but we shared, okay, this is how you would perform. This is your consistent revenue. This is what we are giving you to have that, what we like to call that stickiness, that patient-provider kind of connection that you're gonna get as you move to those land category 4 models, right? We're gonna pay you for these members that go to you. And they said, yeah, that's great, but how would I have done if this were fee-for-service? And they wanted it back. And so although they originally said that they were ready for this transformation, we need to help them along in that journey and say, look, this is the direction we're moving. These are tools and resources for you to understand. Their systems aren't set up to understand some of these population-based payments. And so I think over time, we'll get there. And then maybe on the commercial end overall that you didn't see this kind of large adoption of this because at a health plan, our systems are legacy. They are meant to pay providers at fee-for-service. And so for the health plans to transform how they pay their providers into capitation or PMPMs is a huge lift on the health plan's perspective. And sometimes we don't even have the tools that we need to be able to do it. They just don't quite exist in the way that we need to be ready to build this out at scale. So I think right now what you'll see in the industry is health plans are moving this way. We're building the building blocks to be able to be ready to transform over the next handful of years.
Thank you. It's a little disheartening a little bit when we don't want another pandemic anytime soon where, we might have sort of a breakdown of the payment system again. So, Abby, I'm going to ask you from Medicare Advantage's perspective. As I said, Medicare Advantage has always sort of been, had the highest percentage, I don't want to say leader, had the highest percentage of spending in downside risk, and it still does. But in category 4, it's at 24.5%. That's actually slightly down from 2021 data. So is there anything about the category 4B that Laura was just talking about and capitation that you might be seeing a sort of a pulling back since it decreased a little bit in MA or not?
This was such a curious data point, and I appreciate you sending me on this journey to get to the root cause. Ultimately, what we saw is we saw a similar trend, but it was actually related to broader provider negotiations. So I think it's important to understand and contextualize that category 4 is ultimately intending to replace fee-for-service, and there is sort of a natural negotiation cycle as a payer that, Laura, you understand, that you have with providers. And so ultimately it was not reflective in our experience of providers actually pulling back from an interest in population-based payments, so much as just they wanted to sort of renegotiate their contract with us as a Medicare Advantage.
I like to send people on data point journeys. So, all right, so Olivia, I'm going to round out this first line of question with a question around the health equity. So I found it very encouraging since we know that there's a dearth of data on race, ethnicity, language data, also SOGI data, and yet we can see that there are investments being made by states and by health plans to encourage and incentivize the collection of that data. So what insights do you have from Maine's perspective, Maine Medicaid's perspective, to collect these data? And can you tell us a little bit about Maine's strategies?
Sure. So I think I want to build up the idea that operationalizing these things is sometimes where the rubber hits the road and you really need to spend some time. So in Maine, I think you might find in your own systems as well, these are legacy systems. And what we're at a point of is understanding the data that we do have. Not even to the point necessarily of collecting additional data, but what happens in your own systems today. And I'll give you some examples. What happens when a person self-identifies with having multiple races? Which one is populated in your data? How is that determined? You want to look into these things because they may have some implicit bias or historical they may have reasons why your system 20 years ago was built a certain way that you may not agree with today. And you really need to understand that data when you're starting to use it to make decisions. Another thing that we are dealing with in Maine is that as a Medicaid agency, we operate our eligibility system through an integrated eligibility interface where a person can walk into the door and apply for, or enter their information and see if they're eligible for supplemental nutrition assistance programs, TANF, and the Medicaid program at the same time. Well, all of these programs have different regulatory environments for what data must be collected and how. So while one arm was able to introduce a non-binary gender category, when it went over into the Medicaid claims processing and brokerage systems for our non-emergency transportation, it would break the entire system. So we need to build data systems that can support not just what we know today, but like flexibilities that we're going to need in the future around these strategies. As far as, just want to highlight a few strategies, because I think to an earlier point, we want to make sure that next year we're talking more about how we're using data and how we're making improvements, not just the collection of data. The things that I want to highlight here is that Maine Medicaid is focused, is one of our areas of focus the next year is on social risk adjustment, and I want to call out that the LAN HEAT group has put out a social risk adjustment primer on the website, which I find is really excellent to how to augment your clinical risk with some social risk, which is very important for advancing alternative payment models with safety net and other providers. And the last thing I'll say is we're really focusing on the strategy around team-based models and how Medicaid can pay our share in sustaining community-based community health worker services, which have been really ramped up over the course of the pandemic through all sorts of federal funding, and it's important for payers to pay their part in sustaining that really valuable resource for our communities.
Thanks, Olivia. I'm going to switch it up just a little bit because I want to keep the thread going around health equity. So Laura, in the commercial market, Olivia was just describing about the challenges there, and but also where there are opportunities. So what insights do you have that either are different or similar in the commercial market related to not just collection, but maybe starting to act on? And maybe we're too early, but hopefully next year we are sitting here talking about what we're doing with the data rather than just collecting it. But what about the commercial market?
Yeah, a lot of what Olivia just shared with the Medicaid really resonates still also in the commercial space around the legacy systems. And we're doing a lot of work this year around really still on the collection. How do we get the data back into the health plan and understand, and actually even setting up pilots, understanding kind of what works to be able to get this from different providers, community-based organizations, enrollment, so that we get all of that data. We also had a pilot where we also just wanted to understand from our perspective, if we shared care gap information based on race and ethnicity, would that have any impact into the provider's behavior, right? Like, we get this information, we want to reward on outcomes, what would that look like? And what we actually found out is we had to take like 5 steps back because the providers looked at that and they said, we treat everyone the same. We don't want to look at the data this way. And so what it taught us is that in order to even do this, we actually have to also set up a framework to be able to do health equity training for our providers. So before we can even present the data back out to them, we need to be able to train them and understand it. So like my colleague out here at the main plan, we're at that still infant stage, but we're learning, we're testing, we're trying to see what works, and then apply that to our broader network.
Thanks, Laura. All right, so I'm going to shift gears and go back to downside risk. So Ellen, I'll ask you, traditional Medicare, I said in sort of the overview that of all the lines of business, traditional Medicare saw the largest increase in downside risk arrangements from 2021 to 2022 at 6.2 percentage point increase, which I think might be the largest increase in any category jump of any line of business since we've been collecting data. So what are the major drivers or program initiatives that were taking place in 2022 that drove the downside risk arrangements? And you talked a little bit about the ACO movement into models.
Yeah, and so I think just touching on 2 things, I think most of it really is more participation in existing offerings. So really more participation in the ACOs, both ACO REACH as well as MSSP. So it was definitely growth in ACO REACH and downside risk over that period, as well as the primary care first model. So really having both of those large models as well as MSSP, I think during that period really drove clinicians to accepting risk. I think, though, on the other side, we're also seeing that not all clinicians are ready for that. And it was interesting when you said you built this model and then providers weren't necessarily ready to come. And I think what we're trying to do now is also facilitate a glide path. Mm-hmm. And you saw that last year with AIP for ACOs, but now also with the MCP, where you can join and sort of gain experience and then transition up the track so you get to more downside risk. So I think we're optimistic that there really is not, we talk to a lot of different physicians and there really is not a one size fits all, which is hard if you're making systems investments, right? But so we really have to think about what are the continuum of offerings that will really be there for clinicians as they move toward accountable care.
Be interesting to see how 2023 data shows up, and 2024 for sure. Olivia, I'm going to go back down to you for a second. So this does have to do with downside risk, category 3B, and Medicaid did make its greatest gain in 3B. And I think that might be surprising to some people thinking about Medicaid and given just the payment system in Medicaid in general, that providers moving to downside risk. So what do you think is happening across either state Medicaid agencies, if you want to speak to that, or otherwise about moving into downside risk?
Yeah, and I can't say that all the movement was from Maine, but we did have a little bit. I think it really is about multi-payer alignment, what CMMI is offering state Medicaid agencies and other payers to come on board with. So for us, when CMMI steps forward and puts an initiative on the table, we really look to that and see if we can adopt it in its entirety or elements of it, and ideally see some commercial partners along the way. And when states are able to make that happen, I think they're able to more effectively move to downside risk. I will say I think it'll be interesting to watch this over the next few years, because whenever there's a shift like that, it's really the result of many years of investment that have taken place prior. So I do think Maine will make some progress in the future, but it takes that, a stabilization of the Medicaid rates in the first place before you're able to move towards downside risk, and that's a multi-year process for many states.
So I'm going to end the panel discussion, at least, with a question to Abby, related to the new data we have on lives in accountable care. So you heard from Ellen about the importance of tracking and collecting accountable care and the people that we have in there. So from Medicare Advantage perspective, what do you think MA can do to advance putting more members in accountable care arrangements?
Yeah, I mean, I would echo Ellen's sentiments about providing a glide path. I think it's important. Two things come to mind. The first is sort of streamlining and simplifying the incentive models that we bring to market so that a provider can build their confidence over time and feel more comfortable sort of moving into that total cost of care accountability. And then secondarily, I think it's about looking at the capabilities as a health plan that we bring to bear, because our expertise is managing risk. And how do we translate that in a meaningful way for providers who may be sort of reluctant to dip their toe in the water? And so it's about meeting providers where they are with the appropriate payment model, but then also finding ways to sort of support them with capabilities that really ultimately accelerate their performance in those payment models as well.
I think it'll be really exciting for us to see what percentage and number of lives we have in accountable care next year. So this will be an exciting thing for us as the measurement team. I'm over time, but I just want to do maybe a rapid fire, if I can, maybe 20 seconds each if you can. So what do you think are the most exciting opportunities for APMs in the next 1 to 2 years? Or what do you think is the most exciting opportunity for lives in accountable care in the next 1 to 2 years?
Do I go
Ellen?
first?
Yeah, you can start.
I think we're really learning from the experience of the Innovation Center over the past 10 plus years. And so I'm really excited about some of the new models we're announcing and what will be coming out, because I think in addition to driving toward accountable care, we're really thinking about where there are fundamental gaps where patients are not being served well. An example would be like the dementia model that we just announced. So I think we're really optimistic that these numbers will be even better next year, but we are also on a parallel track addressing gaps.
I think from my perspective, the theme of the day, multi-payer alignment, the more that we can align together, the more we'll see transformation, and I think it'll move much faster.
Okay.
And I'm going to steal the Elevance Health 3 Cs. We think about this as contracting for outcomes, and I think the latest results indicate that we are making meaningful progress there. The second is collaborating for success, and then connecting for health. So how do you unlock and really accelerate performance in that good work that's been done? So I'm really excited to see what we can drive for outcomes.
Great.
And I think it's, for me, and I think for many, it's about the ability of alternate payment models to have money flow into community-based organizations to support folks and care team members that are not historically reimbursed through these models. And alternative payment models represent an opportunity to bring payment to the organizations that are doing that work out in our communities.
Well, thanks everyone for staying, and thank our panelists here for their insights. Thank you. And we'll wrap it up here with some comments from Judy.